Welcome to this episode of Morning Report Emergency Medicine. I'm Alec Weir, and it's time for review, part 2. This is the last episode for this academic year of Morning Report Emergency Medicine. Let's finish reviewing some of those cases. This is an uncircumcised male swelling around the glands with an irreducible prepuce. This is paraphimosis. The thing I got most from it is the penile dorsal nerve block. Go in at 10 and 2 on the dorsal aspect. You're going to have to penetrate into buccal fascia and inject your anesthetic. It can really help with any procedure you have to do, whether it be a paraphimosis or a zipper extraction. Talking pelvic fractures. This is a normal pelvis. Now, I want to show you the line. You want to just follow the edges. And then one of my co-residents pointed out very smartly that I missed one. I missed the teardrop. So right here, this is the teardrop. Any change in the shape of that teardrop is concerning for an occult acetabular fracture. With all this, also keep an eye out on these teardrops. Right here and right here. This patient came in mainly with a complaint of headache, nausea, and vomiting. And this is what her eye looked like on physical exam. This was an acute closed angle glaucoma, and they can present as headache, nausea, vomiting, but this is a painful vision loss. Your ocular findings are decreased vision pain, that fixed mid-dilated pupil like she had, and then increased intraocular pressures. Really anything above 20 is abnormal. The treatment is with ophthalmic drops of beta blockers, alpha agonists, or carbonic anhydrase inhibitors. From the red painful eye to the red painful leg, her point of care ultrasound is we're looking for DVT. You're looking for compression of the common femoral vein. If it compresses, great. If it doesn't, there's a concern for thrombus. And that's what she had. She has phlegmasia cerulei dolens, swelling, blue, pain. That's what phlegmasia cerulei and dolens mean. This is a massive iliofemoral occlusion that needs vascular surgery because it can lead to arterial compromise. These patients are at risk for pulmonary embolism given the size of their DVT burden, and there's an underlying malignancy in approximately 50% of patients. And well, our patient had that PE. You can see here, as well as here, she has bilateral pulmonary emboli. Remember, greater than 50% are associated with malignancy, and here's her CT abdomen pelvis. There's one thing I learned this year, it's to respect the eye. So many great eye cases. This is a 30-year-old male with the chief complaint of left eye pain. He was actually hit in the left eyeball by a taser barb. He also had 2 in the chest and 1 in the abdomen. Some police departments can remove their own taser barbs, or if it's a civilian taser barb, these will be coming to the emergency department. You can anesthetize the area, grab the barb perpendicular to the skin with a pair of needle drivers and as close to the skin as possible, and then pull perpendicular to the patient, and use 11 blade if needed to make a smaller opening in the skin. But remember, he also took one to the eyeball. And as you can see, he's got a large metal foreign body and lodged into that left globe. He has a ruptured globe. You can be blunt or penetrating trauma. You'll have a teardrop or a regularly shaped pupil. You want to look for Seidel's sign, which is the flowing of aqueous humor over the anterior surface of the eye when it's stained. You can use CT or ultrasound for foreign body, but if you ultrasound, be careful not to put any pressure onto that globe. And with that, do not check intraocular pressures on these patients. Here's a picture of another patient we had. You can see that irregularly shaped pupil, and actually the iris has migrated to fill the defect where the penetrating injury was. And this one also has an associated hyphema. This is a peritonsillar abscess. You can see uvula deviation right in the area where you expect. These patients will have difficulty opening their mouth, some trismus, pain. And now usually I used to do these blind, but this was the first case I had done ultrasound guided and used an endocavitary probe. There's our abscess. And with ultrasound, you can also very clearly see where your carotid artery is, the big concern when draining a peritonsillar abscess. You can actually visualize that needle the entire time. Since this case, I've done it multiple times with an endocavitary probe, and I'm never going back to doing these blind. Now, this case generated a lot of discussion in our residency. It's a 35-year-old male. He was found by EMS outside of a residential home that was actively in flames and was dragged out unresponsive. By the time he got to the emergency department, he was a little more awake and he was talking, but his pH was 7.1. He's incredibly acidotic, and his carboxyhemoglobin is 23.4. This is a concern for cyanide poisoning. Now, carbon monoxide poisoning with a carboxyhemoglobin of 23 in this case, you also want to be concerned for cyanide poisoning. Things that can point you in that direction are lactates greater than 10, and you want to treat with 100% O2 for the carbon monoxide portion, and then hydroxycobalamin for the cyanide component. Now, where is our hydroxycobalamin? Where is our cyano kit? We've got a few in our pharmacy that we keep just for these cases. And I like this case here because we have a follow-up that I've added, and you'll see in just a minute. 17-year-old male who presented with the chief complaint of palpitations, and here was his resting EKG. It's a very classic Wolf-Parkinson-White resting EKG. You can see not only does he have the short PR interval, he has the delta wave present in practically every lead. Now remember, the delta wave won't actually be present in every lead unless it's as classic as this one, but that short PR can help to clue you in that there's Wolf-Parkinson-White syndrome. Now with the syndromes associated with tachydysrhythmias, especially wide complex AFib. Now this case came in just 1 week after I posted the Wolf-Parkinson-White case, and it was sent to me by one of our residents. Heart rate of 192, irregular, wide complex. This is AFib with aberrant conduction from Wolf-Parkinson-White syndrome. This patient was stable and treated successfully with procainamide. And our last case, the most recent case, the only reason I'm redoing it, even though it's a review, it was so recent, is because I got so much messaging about how my French is terrible and I can't pronounce this disease, so we're going to give it another shot. 53-year-old female, leg pain, swelling after a motor pedestrian collision. 4 days earlier was seen in an outside hospital with no injury identified, and this is what her leg looks like. X-rays normal except for some edema. This is a Morel-Lavallée lesion. Hopefully that's a little better for you. This is a closed degloving injury. Now, strictly speaking, Morel-Lavallées are only when it overlies the greater trochanter, but this term gets used for any closed degloving injury. This is when the subcutaneous tissue separates from the fascia, and it's associated with considerable morbidity in the trauma patient that needs surgical debridement, and that's what this patient received. That's all, folks. Thank you so much for sticking with me this year. It's been a lot of fun for me to do this. I will still post on this site. It probably won't be weekly cases. I'm just not sure what my next year looks like as an EMS fellow. But you can always follow me on Twitter at @Weir_Alec, or if you just need to get your fix of these great cases, subscribe to the channel below in the summary section for the clinical correlation. This comes from two of the up-and-coming third years that are taking the torch, Ian Bodford and Liang Liu. They gave me a little taste, a little morsel of their first episode, and it is great. So follow them, subscribe to them for more cases. I hope you've enjoyed this and maybe learned something this year. I know I have. Thank you so much for taking the time. Keep your eyes out for those interesting cases.